Good morning, everyone. Today I am presenting a seminar on the topic of renal cell carcinoma classification, etiopathogenesis, and clear cell morphology. Let's start with the introduction. Definition: the renal cell carcinoma is an adenocarcinoma arising from the renal tubular epithelium. It constitutes the most common primary malignant tumor of the kidney. It is accountable for approximately 85 to 90% of all primary renal malignancies in adult. Represents about 2 to 3% of all adult systemic cancer. Age distribution primarily affects the individuals in the 6th and 7th decade of their life, that is 50 to 70 years. Gender ratio shows a distinct male predominance with a 2:1 male to female ratio. WHO classification of RCC. The World Health Organization classifies the malignant renal epithelium tumors based on their morphological features, unique cytogenetic changes, and molecular pathway. Mainly, we have 4 types: clear cell RCC, papillary RCC, and chromophobe RCC. Collecting duct carcinoma. Prevalence: the clear cell RCC, it's about 70 to 80%. The cellular origin is proximal convoluted tubule. The main finding is the loss of chromosome 3p and VHL gene mutation or deletion, whereas in the papillary RCC, its prevalence is 10 to 15%. Cellular origin is proximal convoluted tubule, same as that of clear cell RCC. In the findings, we see a trisomy of 7, 16, and 17 chromosome and mid-proto-oncogene alteration. The chromophobe RCC, its prevalence is 5%. Intercalated cells of collecting duct as a cellular origin, multiple hypodiploidy is seen, whereas in the collecting duct carcinoma, its prevalence is less than 1%. Cellular origin is the collecting duct of Bellini, which is a highly aggressive variant. Multiple complex chromosomal deletions are seen. Etiology and risk factors. First, we have lifestyle factors. Tobacco smoking and obesity. Tobacco smoking is the most significantly established environmental risk factor. Doubles the risk of development of RCC. It's responsible for highly 30% of the cases. Obesity, it's a strong linear correlation, especially seen in females. Increased risk is related to metabolic syndrome and altered steroid hormone pathway. Chemical and industrial exposure also increases the risk of RCC. Occupational exposure to asbestos, heavy metals, and petroleum products increases the susceptibility. Underlying medical states, like acquired cystic kidney disease, occurs prominently in patients undergoing long-term chronic hemodialysis. The risk of developing RCC increases up to 30% in these patients. Hypertension is an independent predisposing risk factor, regardless of the antihypertensive medications they are taking. Routine screening via renal ultrasonography is indicated for the patients on long-term dialysis who presents with hematuria or dynamic architectural changes within the pre-existing cysts. We have pathogenesis, 2 types: familial or sporadic. Sporadic carcinogenesis, which is mostly seen as the main pathogenesis, it's in 95%, whereas familial is only 5%. Sporadic carcinogenesis presents as typically a solitary or unilateral lesion in the older adults, predominantly driven by somatic mutations and epigenetic silencing induced by environmental carcinogens, whereas the familial is characterized by the younger age of onset, bilateral and multifocal tumors. It's inherited in an autosomal dominant fashion, provides an essential modeling for understanding molecular pathway details. Molecular pathogenesis, the pathway. Loss of VHL gene function, either due to deletion, mutation, or methylation, leads to an inability of target HIF-1 alpha for ubiquitination and destruction, which leads to an intracellular accumulation of HIF-1 alpha and translocation to nucleus, which leads to an overproduction of VEGF, PDGF, and EPO. Hypervascularization. Normal physiology. In well oxygenated cells, hypoxia induced factor 1 alpha undergoes hydroxylation, triggering binding of VHL protein complex. This targets hypoxia-induced factor 1 alpha for rapid degradation via ubiquitin proteasome system. The pathological state, the metabolic switch. When a VHL is mutated or lost, the stability of HIF1 alpha and acts as a constitutive transcription factor. It inactivates the target genes responsible for angiogenesis and metabolic growth support. Therefore, the vascular endothelial growth factor and PDGF beta. Morphology: gross appearance of clear cell RCC, macroscopic findings. Location: it arises characteristically from the renal cortex, often expanding towards the poles. Most commonly, upper pole is involved. Color and appearance: classically present as a bright golden yellow to orange cortical mass. The classical color is mainly due to intense intracellular accumulation of lipids and glycogen within the neoplastic cells. As you can see in the picture, there is a large cortical neoplasm at the upper pole with a characteristic variegated golden yellow surface on the cut section. You can see a dark red focal hemorrhage and cystic breakdown zones as well. Architecture: it's a well circumscribed, bocellated spherical mass that comprises adjacent renal parenchymal margins. Secondary changes: it frequently exhibit large focal areas of hemorrhage, grayish necrotic area, and cystic degeneration. Microscopic feature: cellular morphology, rounded or polygonal cells which is having an optically clear or vacuolated cytoplasm. By that clear, the cytoplasm is packed with the glycogen and lipids. The standard formal fixation and paraffin processing dissolves these material out, leaving an empty space. Therefore, they appear as a clear cytoplasm. Nuclear features: they are centrally located, rounded vesicular nuclei. Nucleolar visibility depends heavily on the tumor grade. Growth arrangement: arranged in sheets, solidness, cords, or delicate trabecular network. Stroma: separated by a highly intricate fine network of thin-walled branching capillaries. You can see in the picture the cells are arranged in a glandular pattern. We can see clear cell, solid pattern. Clinical features and paraneoplastic syndrome. The classical triad includes the hematuria, flank pain, and palpable abdominal mass. Paraneoplastic syndromes, which includes polycythemia with inappropriate tumor secretion of erythropoietin, hypercalcemia, synthesis of parathyroid hormone related protein by tumor cells, Cushing's syndrome, secondary to ectopic ACTH production, and Stauffer syndrome, reversible hepatic dysfunction without liver metastasis. Thank you.